Hello, my name is Kirsty Maclennan and I'm an obstetric anaesthetist in Manchester. And I'd just like to say thank you very much to Damien and the organising committee for inviting me to speak today on delayed recovery from neuraxial block. I'm very mindful that I'm not able to be in person with you today, so I've put my contact details on my Twitter feed here, and please do feel free to contact me with any queries that you may have. So we're going to start by just looking at the aims of the talk today. So over the next 20 minutes, I'm going to talk to you about consideration of causes for neurological injury following delivery, not just regional anaesthesia, but obstetric as well. Some national guidelines for monitoring both during and following regional anaesthesia in obstetrics. A methodical approach to take if you are to encounter a mother who is left with neurological damage following birth. And all this will enable you to have prompt recognition when you're dealing with a spinal cord emergency. So we're going to start by some good news. Always good to start on the good. So the good news is that the instance of major complications from central neuraxial blockade in the obstetric population is actually quite rare. Our patient population are healthier. They have less immunocompromised situations. They have reduced spinal cord abnormalities, and the duration in which the epidural is in for is often shorter. They also tend to be hypercoagulable, particularly towards the end of their pregnancies. So when looking at complications, we tend to look at either NAP3 or the NOAD data. So NAP3 was from 2009, and we'll have a little look at that first. So what the NAP3, so our national audit project, showed was that most complications leading to harm occurred in the peri-op setting. The incidence of complications in obstetrics is actually extremely low. There are approximately 140,000 labour epidurals per year. And although obstetrics counted for 45% of the 700,000 cases that were reviewed in NAP3, there were only 7 of the 52 cases that actually went for final review for permanent nerve injury were obstetric. Of those 7, a number of them were lost to follow-up. So if you assume a pessimistic view that these patients who were lost to follow-up did go on to have permanent harm, then the pessimistic view would say that permanent nerve injury can occur 0.62 per 100,000 times following a labour epidural, 1.5 per 100,000 times following a obstetric spinal, and 3.9 in 100,000 following a CSE. But if you look at all of the data together, any central neuraxial blockade in obstetrics, looking at an optimistic view, the risk of permanent harm is 0.3 in 100,000. Now, if you compare that to the data from the NOAD database, which looked at over 3 million deliveries between 2009 and 2014, there were 28 reported cases of permanent nerve injury. And this gave a rate of 5 per 100,000, which is obviously a lot different to that of the NAP3 data. But the thoughts on that are, as this was a voluntary data submission, and perhaps less serious injuries or more minor nerve injuries were included compared to the NAP3 data. Okay, so now we're going to look at causes of neurological injury. And I want to start by talking about obstetric injuries, because actually they account for probably most of the injuries that you'll see in your practice. Some studies say that obstetric nerve injuries can occur in 4% of all cases. The commonest reason is compression, followed by ischemia and transection. Now, of compression, the most common nerve which is injured during birth is the lateral femoral cutaneous. And so typically this will give you purely sensory impairment in the lateral aspect of your thigh, and it can also lead you to feel very heat sensitive in that area, but it has no motor component. The femoral nerve, commonly injured for prolonged lithotomy. The lumbosacral plexus and the common perineal, that's caused by compression between the sacrum and the fetal head. So things like obstetric forceps deliveries, particularly with the common perineal nerve damage, as you'll all know, when patients are in lithotomy for a long period of time, the head of the fibula can cause compression. With the lumbosacral plexus damage, the risk factors for that are if the patient is a primate of short stature with a big baby. Obturator nerve, again, fetal head and forceps in the pelvis are common causes for nerve damage. Moving on to ischemia, the anterior spinal cord infarction is a syndrome that you need to be aware of. In 15% of mothers, their blood supply for the anterior spinal cord will come from your internal iliacs, and during long labours, these can be compressed. If you have compression of those, that can often be compounded by hypotension, be that from a bleed or from an epidural even, and the combination can cause you to have ischemia, which can lead to signs of low motor neuron signs. So you have a reduction in or loss of your reflexes, you have decreased your power and sensation in your legs. But one thing that will remain intact is your dorsal column. So although pain and temperature sensation will be reduced, your vibration sensation will still be present. So that's just something for you to be aware of. Okay, then anaesthetically, there are a number of reasons why you can have neurological problems following a regional anaesthetic in obstetrics, and I'm going to look at each one of those individually now. So the first one, direct trauma. Some studies quote incidence of approximately 1 in 3,000 for an epidural and approximately 1 in 2,000 for a spinal, because the spinal cord can be affected more in a spinal than an epidural. Now, the key for this is if you have paresthesia on needle insertion, just stop. And certainly don't inject. Contributory factors are anything that can make it more difficult. So obesity, a patient that's moving, but obviously other problems like anatomical problems with your spinal cord stenosis or spinal cord anatomy problems. Now, those studies that quote that incidence are reasonably old now, and it may be that with the use of ultrasound, we've actually reduced those risks, which would be good to see. Epidural abscess. Epidural abscesses tend to be an insidious onset. That's how they're described. The mother tends to have made a full recovery from her regional anaesthetic, and then the symptoms come on after that. They can be associated with severe pain and focal signs, obviously temperature and signs of sepsis as well. Spinal epidural hematomas. The risk factors of this are anything that makes the epidural harder, but also anything that increases the risk of coagulopathy. And one of the major things we need to think about is timing of low molecular weight heparin and other drugs. And for that, we've got the nice guide from the association. This tends to have a more acute onset. Pain, radicular pain in nature, can lead to weakness, sensory abnormalities in the dermatome distribution, bladder and bowel involvement. But the key for this is that it's time critical. It needs to be evacuated within 8 to 12 hours before permanent nerve damage can ensue. So that is the time critical issue. Meningitis, this is the quoted instance, but that does come from non-obstetric practice. And one of the commonest pathogens that is found in the meningitis following a central neuraxial block is Streptococcus viridans, which has been isolated in the throats of the anaesthetists who've been citing them. So wearing a face mask when you put in your regional block. And then adhesive arachniditis. Following case reports of accidental injection of chlorhexidine into central neuraxial blockades, it became apparent that that can cause severe problems with inflammation, reduction in blood flow, and nerve atrophy. So the association very much recommends that we don't use 2% chlorhexidine when we do our central neuraxial blockade, but to use 0.5%. And how you use it is important. So you need to be, if you're using it as a spray, that needs to be before you open your pack. And if you're using it as a cleaning solution, then that should be kept separate from your workstation where you have all of your needles on. Okay, so we've talked through the considerations of causes, and now we're going to move on to the guidelines for monitoring. And for that, we're going to start in the actual labour period. So this lady's in labour, she's got her epidural, and we're going to talk now about what monitoring she should have when in labour with a regional technique. So we've got 2 guidelines that we'll look at. We'll first look at the NICE guidance. So the NICE guidance at the moment is up for review. But currently, if you look at the NICE website, it said that all you need to do when a woman has an epidural in, additional to the cardiovascular monitoring, is to do hourly sensory block only. It doesn't talk about motor block. But in 2020, the joint guidelines came out from the Association of Anaesthetists and the Obstetric Anaesthetic Association. And they gave 4 critical points or 4 recommendations. The first one was that the anaesthetist should be alerted if a mother cannot straight leg raise when she has a labour epidural. Following a spinal or an epidural top-up, the mother should be able to straight leg raise after 4 hours. And the woman should be informed of why straight leg raising is being assessed, and she needs to be party to that. So if she is unable to move her legs at 4 hours, she really does need to be asking for assistance or highlighting that with the midwife, who can get hold of the anaesthetist. And labour units need to have a policy to guide the assessment, management and escalation of care. And I'm going to come on to that just a little bit later. So to talk about how we in Manchester have enabled our monitoring in labour, we have an e-learning programme for our midwives when caring for an epidural. So we've introduced the concept that they need to be straight leg raise monitoring, and they need to be doing that hourly. So they do that hourly with their sensory block height check. The anaesthetist, we attend multidisciplinary team ward rounds every 4 hours, and at those ward rounds, the anaesthetist will also check that the mothers with epidurals can straight leg raise. And we refer everybody to the OEA safety poster, which I'm just going to zoom in on now, which basically talks about the importance of hourly monitoring in labour and then being able to lift your leg up 4 hours after an epidural top-up or your last spinal dose. And if you can't, you need to alert your anaesthetist. So that's a post that we have up and we make sure is included in the education programme. So we've looked at guidelines for monitoring, but now what I want to talk you through is the approach that we take in Manchester for when a patient or mother has a neurological deficit following regional anaesthetic. And I'm going to show you the booklet that we use, which is down here. Oh, yes, the first thing I'm going to do is talk about the regional anaesthetic alert bracelet. So I'm not sure if any of you have seen this in Anaesthesia News by Rachel Mathers and her group. So when the guidelines came out, in order to be able to reach the target of making sure that the ladies can raise their legs after 4 hours, they introduced a bracelet, which they call the Regional Anaesthetic Alert Bracelet. And Rachel describes this very nicely in her article in Anaesthesia News. So the bracelet is put on at the WHO sign-out. The time is recorded as to when the woman should be able to straight leg raise. And if the woman can straight leg raise at that time, she can remove her own bracelet. If she can't straight leg raise at that time, then she needs to alert her midwife to get an anaesthetic review. The feedback from this was really positive. Patients say that they felt safer, able to speak up, that they even set a timer for when the bracelet should come off, and that they felt it was the first milestone in getting home. So we thought that was a great idea in Manchester. The only problem that we have is we have a really diverse set of patients who have very different languages. And so putting a bracelet on would be difficult for those who are unable to read that language, or literacy. Some people struggle to read, and then compliance would even take it off. So with us, for our patient population, that probably wouldn't work, but we like the idea, so we wanted to modify it. So what we have coming through our system at the moment, it's being printed just currently, is we are going to go with a regional anaesthetic alert bracelet. We're going to stick with the colour yellow. White is our name band, red is our name band if they have an allergy, and green means that the mother's got a vaginal pack. So yellow fits well in our colour scheme, and we're going to have 3 things on it. The first thing on it will be a straight leg raise time. So it'll just say straight leg raise at and 4 hours post the epidural top-up or the spinal. It'll then have a time, which is 6 hours after regional anaesthetic for the catheter to come out. And then it'll have a QR code on it. And I've been specific about the fact it's dynamic because it needs to be able to change in time as we add more languages. And the QR code, the women will be able to scan themselves, and it will take them to a patient information leaflet, which we are going to translate into all of our major languages. So that is work that we've got ongoing at the moment. And that is the poster for the patient information, which has been adapted by one of our medical students from Nico's original poster, which is on the OEA website. Okay, so that's how we're going to inform our women, and then to inform our staff, we've got a really clear guideline in the way of a pathway. So we use pathways a lot. We've already got a pathway that we use for our post-dural puncture headaches, which works really well for our anaesthetic team. So we've devised another pathway, but this is purely for neurological deficit following regional anaesthesia. And I'm just going to talk you through the pages of it now so that you know what it shows. So the first page, it has the contact details, and it has the details of the neuraxial procedure that's been performed. So it talks about the size of the needle, the level that's been instrumented, the number of attempts, any immediate complications, including neuralgia or blood in the catheter, the time of the last dose, if it's an epidural top-up, the time the catheter is removed, and specifics about the timing of the low molecular weight heparin. The next page is a history of presenting complaint and any past medical history, including pre-existing neurology. Then just a signpost of risk factors, including sepsis, coagulation, if the patient's immunocompromised or diabetic. And then is there anything relevant in the obstetric history? If the patient's had a normal vaginal delivery, if they've had an instrumental, has it been a cesarean, has it had a prolonged second stage, or has the mother been in prolonged lithotomy for either second or third stage? Then it goes on to the examination, tone, reflexes, sensation. And in the sensation, the anaesthetist who's reviewing the lady will just have to colour in or shade the area that is affected. And then the power assessment. And we've been really specific about this because we think sometimes people are not entirely sure what movement links to what nerve supply. So we've been really specific about that and really specific about how we want them to test it so that we know they're testing everything with a really clear way of doing it. Because that means that if we test them the next day, we're using exactly the same algorithm to do that. And then some red flag signs that we really want people to be aware of: persisting progressive neurology, nerve root pain, symptoms including bladder and bowel symptoms, saddle anaesthesia, bilateral signs are a bad sign if there's severe back pain, and any signs of symptoms of meningism. Now, following the assessment, they'll come to this page, which will allow them to work out where they think the neurological problem lies. So you have your sensory findings, your motor findings, what nerve root it may map to, and then what treatment algorithm you now need to go down, if that's referral to the physio, or if it's referral to neurology as an outpatient, or is it more urgent? Do you need to refer to neurology now and get an MRI scan? So that's the algorithm. And then in order to get an MRI scan, we take you to this page. So this is if you're suspecting an epidural lesion. Bit of information here about it if you think it might be an epidural abscess, other things you need to do if you're considering an epidural hematoma. Anything with red flags brings you to this page. It has to be discussed with the consultant anaesthetist, and then at that point you decide how to get your imaging, and that will depend on if it's in hours or out of hours. And we've stuck with MRI imaging rather than CT scanning, so this is all about how to access MRI scanning. And to make this booklet, we've involved the neurosurgeons, neurologists, and really importantly the MRI scanning team, because without them we can't get our images at the end. So I hope you found that run through helpful. And if there's anything I can do, any information I can share with you, please don't hesitate to ask. And thank you very much for listening to the presentation today.